Good afternoon. I'm Alan Bell. I'm an assistant professor in the Department of Family and Community Medicine at the University of Toronto. As Vice President of Thrombosis Canada, it's my pleasure and privilege to welcome you all and moderate today's event, Thrombosis and COVID-19 Canadian Expert Perspectives. Before we begin, I just wish to point out that the system has automatically muted all participants except the speaker. We welcome and encourage your questions, and to facilitate the process, please use the question and answer function button at the bottom of your screen. You can see it by hovering over the bottom of the screen. We'll try to address as many of these questions as time permits at the end of the session. I would like to take a moment to introduce and thank our planning faculty. It's been my great pleasure to work with Dr. Alan Tran, Dr. Brian Birnbaum, Dr. Jim Duquettis, Dr. Peter Gross, Dr. Jeff Habert, and Dr. Sudeep Shiva Kumar, who all put their work forward into this program on a pro bono basis, so thank you all. Next slide. Our learning objectives for today are at the end of this program, participants will be able to incorporate the latest information about thrombosis and COVID-19 into their clinical practice, to effectively manage thrombosis and patients on anticoagulants remotely, and to discuss the hematologic coagulopathic issues that surround COVID-19 and for which there is so much we still need to learn. Here are the disclosures of today's speakers. I'll give you a moment to review those. Next slide, please. This program has received financial support from Pfizer in the form of an unrestricted educational grant. Pfizer had absolutely no role in the creation or review of any of these slides, nor were they privy to any of these slides prior to the presentation. Further, with regard to mitigating potential bias, the agenda and faculty for this program was developed by the Scientific Steering Committee from Thrombosis Canada. All faculty have been directed that any recommendations involving clinical medicine are to be based on evidence that is accepted within the profession, and all scientific research referred to, reported, or used in the CME-CPD activity in standard or justification of patient care, in support or justification of patient care, recommendation conforms to the generally accepted standards. Next. Our agenda today is going to walk us through these topics. Following this very brief introduction, we're going to get a review of where we're at with COVID-19, followed by some of the arterial complications of COVID-19 with regard to stroke and myocardial infarction. We're going to talk about coagulopathy in relation to COVID-19, as well as anticoagulation prophylaxis and treatment. Managing your thrombosis patient remotely in the COVID era is going to be presented by Sudeep Shiva Kumar. And then finally, I'm going to walk us through a series of cases that I think are going to be particularly relevant to primary care, but also I think relevant to all healthcare professionals during COVID. Next slide, please. Oops, wrong way, I think. Next slide, please. Right. So what is the challenge that we're facing in primary care? You know, as a primary care physician, my world has been turned upside down, and I think most healthcare professionals find themselves in the very same situation. With regard to venous thromboembolism and other thrombotic conditions, nothing has changed with regard to the disease state, but everything has changed with regard to how I am expected to manage it. In-person visits have become a rarity. The vast majority of my patients continue to be managed remotely, mostly by telephone with the assistance sometimes of visual clues or photographs that are emailed. Very different from what I am used to. And I think in the specific case of venous thromboembolism, a physical examination is such a useful tool in this disease, which has largely been eliminated from my ability to assess patients. You know, the emergency rooms are a different place now. Right now, I don't think they're facing a huge burden, but certainly during the peak of the first wave, there was a very serious concern about overloading the emergency rooms. I think as the second wave moves forward, we are going to see again, certainly the potential of our emergency rooms being overrun. Further, our patients are not interested in going to the emergency rooms for fear of coming in contact or contracting COVID-19, certainly something that would definitely complicate their course. With regard to INR monitoring, well, patients certainly aren't anxious to attend laboratories. I am not anxious to have my patients attend laboratories again because of their risk of exposure or of contracting COVID-19. We know that for our patients who do sadly contract this viral illness, that is associated with thrombotic and bleeding complications that I think we as healthcare professionals all need to be aware of. And then our follow-up of COVID-19 patients with or without thrombotic complications is another challenge that healthcare professionals are all facing. And in the trenches in primary care, we certainly feel that acutely. Next slide, please. So with that, as I say, very brief introduction, I would like to introduce our first speaker, who is going to address the issue of where we're at with COVID-19 and the internist perspective by Jim Duquessis. Jim is professor of medicine at McMaster University and has authored over 200 impactful scientific publications. He is director of vascular medicine at St. Joseph's Healthcare in Hamilton, and of course, he's president of Thrombosis Canada. So Jim, I'll turn it over to you.
Thank you very much, Alan, and hello, everyone. My task in the next 5 or 10 minutes is to provide an overview of where we're at with COVID-19, and I think we all recognize it's important as we are into our second wave, and this is going to be combined, of course, with our typical flu season. So much of this will be review for you, but I think it is helpful given this context, and here's some information about the etiology and epidemiology of COVID-19 that I know you're all familiar with, some of the risk factors for developing adverse outcomes related to this disease. Next slide. In terms of the pathogenesis, again, material that you're familiar with, I think it is worth noting that since the virus uses the long ACE2 as a receptor to enter the cell and render its effect, the practical question is, what about those patients who are already on medication like an ACE inhibitor or an ARB? Do these medications increase the risk of complications from COVID? And the short answer is no. So your patients who are on these medications can continue them if clinically indicated, but they should not be used for primary prevention of COVID-19. You're familiar with the incubation and a contagious period. Next slide. And in terms of the diagnosis, once again, this is something that we're going to be seeing more and more of over the coming weeks, I would expect. And just to point out that in terms of the diagnostic testing, typically done by the nasopharyngeal swab, that this has high specificity, so very few false positive results, but the sensitivity varies depending on when the test is done. It's highest when it is done early on in the symptom complex, when much of the virus is still in the upper respiratory tract, and then lower if the testing is done later on when the virus is more active in the lower respiratory tract. So keep that in mind when you are assessing your patients and interpreting these test results. Next slide. We know that COVID-19 touches pretty well every organ system in the body, and we're familiar with its presentation, and I think our role will be trying to differentiate COVID-19 from other viral respiratory infections, whether they are influenza or the common cold that is upon us over the next few weeks and months. Next slide. This rather busy slide gives an impression of what the clinical course of COVID-19 is and how early on it is mediated mainly by a viral response and then subsequently by an inflammatory response. So the more inflammatory response you get, the more severe the disease is, the more organ systems it affects. And of course, one of these is the vascular system and the coagulation system, which we'll be focusing on today. Next slide. There's been much talked about regarding treatments of COVID-19. This slide is an attempt to summarize where we're at with the evidence as of October 2020. We are aware of the supportive nature of treatment, that patients with severe disease are anybody who may have an oxygen saturation of less than 90-94% on room air. So oxygen is an important part of treatment, and we've recently learned that corticosteroids are an important component of treatment in patients who have severe manifestations of COVID-19. Whether this is with dexamethasone at a dose typically of 6 milligrams per day, or methylprednisolone, solumedrol 32 milligrams, or prednisone at 40 milligrams. So these are lower dose regimens, relatively speaking, but they appear to confer important reductions in overall mortality. Remdesivir, the antiviral agent, has been looked at in more severely ill patients, and it appears to have modest benefits in terms of reducing symptoms and a non-significant reduction of mortality. And then, of course, antibiotics if there is superimposed bacterial infection, but not routinely used. So really our triad of treatment is supportive care, oxygen therapy, corticosteroids, and possibly remdesivir. In terms of the other investigations which have been under intense study over the past several months, we are still awaiting trial results from anti-inflammatory agents, example colchicine. We've learned that hydroxychloroquine does not have any benefit for patients who are hospitalized or for primary infection. Other treatment regimens, including antivirals, immune modulating agents, convalescent plasma, which has been approved in the United States for major emergency use access, but not in Canada. Monoclonal antibodies against the spike proteins are still investigational therapies. You'll hear a lot more about the use of anticoagulants as potentially a mechanism to mediate against some of the effects of COVID-19, and the trials that are ongoing to see if it can improve mortality and morbidity in these patients. So I want to move on briefly to talk about COVID-19 and cardiovascular disease, specifically stroke and myocardial infarction. And I think the first overall point to take away is that this is a bidirectional association. In other words, patients who have cardiovascular disease risk factors like hypertension and diabetes appear to be at higher risk for developing severe COVID-19 infection and complications from COVID-19. And in the other direction, having COVID-19 may increase your risk for cardiovascular complications. Next slide. So the first of these is there is increasing evidence to indicate that having COVID-19 increases your risk for stroke. And the risk, although relatively low in absolute terms, so it appears to be less than 2%, is higher than with either viral illnesses like influenza. And of course, stroke in itself is a serious complication that we want to try to avoid. Now, the mechanism here is still unclear, and there are multiple pathways that have been postulated to lead to the final common, in this case, disease being an ischemic stroke manifestation. So it's hard to say how we are going to influence these mediators, but certainly one has to keep a broader approach than simply the type of stroke that we see in everyday practice that is either atherothrombotic or thrombotic in origin. And as I said, we've recognized that COVID-19 increases the risk of ischemic and hemorrhagic stroke. Next slide. Moving on to myocardial infarction, we see that there are a lot of the same mechanisms that are in play in terms of the pathogenesis. The manifestation of myocardial infarction is thought to be mostly related to a type 2 mechanism or a supply-demand mismatch, as opposed to the typical sort of atherosclerotic coronary plaque rupture mechanism. And therefore, the invasive management with a view to coronary angiography and vascularization has a limited role. So you have to consider more the pathogenesis of conventional atherosclerotic mechanisms in this case. And here we see that myocardial injury can be manifest or can result from different pathways, whether it's from the inflammatory or cytokine storm that's manifest by elevated levels of interleukin-6, ferritin, LDH, and D-dimer, or direct myocardial dysfunction from the effect of the virus within the myocardial cells that we see typically with a viral myocarditis or stress-related cardiomyopathy or myocarditis. And in terms of the next slide, we see how all of these factors are influencing the pathogenesis of an acute coronary syndrome. So as with stroke, there are a higher proportion of patients who have myocardial injury than one would expect with other viral illnesses, in this case between 7 to 17%, although as I said, many of these are due to type 2 ischemic injury. The final point I would make is that in the patient who does develop a myocardial infarction, the approach is the same as in patients who do not have COVID-19, but we recognize that the underlying pathophysiology and mechanisms may differ. So with that, I want to turn it over to the main focus today, which is to talk about COVID-19 and its effects on coagulation and thrombosis.
Thank you very much, Jim. Difficult topic to cover in such a brief time. Our next speaker is Dr. Peter Gross. Peter is Associate Professor of Medicine in the Division of Hematology and Thromboembolism at McMaster University. He is head of the Clinical Thrombosis Service at Hamilton Health Sciences. Peter's basic science laboratory at the Thrombosis and Atherosclerosis Research Institute, the TARI, focuses on models of thrombosis and hemostasis. He is a member of Thrombosis Canada's Board of Directors. And with that, Peter, the floor is yours.
Thank you, Alan. So I'm going to talk with a few slides about the basic science of what we think is the pathophysiology of the coagulopathy of SARS-CoV-2, and sort of talk about that and a little bit about the venous thrombosis. And then I'm going to explain something which is termed the decline effect, about the incidence of new findings and new illnesses. Next slide, please. So I'm going to show a number of these review images from different review articles. Now, I want to preface all this by saying that a lot of the science is being done on this, and a lot of this is not answered when these review articles came out and is being done at the moment. So on the left, we have a lung with an alveolus and a microcapillary and the circulation, and that's all healthy and things are going along and everything's happy. On the right, we have SARS-CoV-2 infecting macrophages, infecting endothelial cells, epithelial cells, and this results in a cytokine storm, which causes a number of changes in the microvasculature, including the activation of neutrophils releasing nets, von Willebrand factor from the endothelial cells. Platelets are activated. You might get microthrombi circulating von Willebrand factor, and the lack of anticoagulant processes, including soluble p-selectin and the cleavage of thrombomodulin. Next slide, please. So this is sort of the same thing in a bit of a different depiction on how it could cause, all these changes could cause venous and arterial thromboembolism and microvascular thrombosis. So SARS-CoV-2 infects endothelial cells and epithelial cells. This increases vascular permeability, that's the VP. This recruits immune cells, inflammation, cytokine storm, nets from neutrophils, activated platelets, makes that worse. Coagulation is activated. There's increased tissue factor expression on the white cells, probably on the epithelial cells too. There's fibrinolytic changes, an increase of pi1 as well, and there's complement changes, and some of these things happen in other viral pneumonias, and the work really is to try see which of these things is specific for SARS-CoV-2. Some of the more interesting papers that came out even after the slide deck was submitted were about specific factors of the complement pathway. Next slide, please. So basically, this is just being sick in the ICU with another viral pneumonia. It's just worse with SARS-CoV-2. Next slide, please. All right, so what are the common hematology lab abnormalities that you can see in COVID-19, and what do they mean? So platelets are slightly reduced in some patients. It's not being associated with mortality. There's often a lymphopenia. 80% of patients have an absolute lymphocyte count of under 1.5, and severe lymphopenia and LDH elevation is often seen in critical illnesses. Sometimes you'll see a prothrombin time prolongation, and this is also being associated with mortality. The early data showed D-dimer was markedly elevated and it was prognostic of mortality. And then fibrinogen is sometimes elevated late in the disease and not usually reduced. Next slide, please. So there's some ongoing trials. A Canadian CHR1 called COVID Beacons is going on to determine novel coagulation, platelet fibrinolytic, and other biomarkers of disease progression and prognosis in COVID-19 disease. There's many other trials as well, and these are all well-funded for a short period of time. So I think within 9 months to a year, we're going to get very exciting data about this. Next slide, please. So I'm not going to talk about the decline effect, which is a bit sobering to know. So the decline effect was first described by Joseph Banks Rhine in the 1930s, and it defines an effect that can occur when scientific claims receive decreasing support over time. So in medicine, we kind of call that an issue of low sample size or a regression to the mean, where the true rate of a clinical finding is lower when it's studied systematically than when it's initially being thought about. So, as a clinical investigator, you might start a trial looking at a certain condition because you think that happens a lot. And when you actually start looking for it, you find less of it. Next slide, please. So this is the decline effect in COVID-19 and venous thrombosis, okay? So in April, we're all panicking with the first paper by Kui et al. from the Wuhan region, mostly ICU setting in China, where they had 25% VTE in 80 patients. We didn't know how many of those patients were receiving prophylaxis or how they were being diagnosed. But then we started in May and June getting reports from places who we thought knew how to look after venous thrombosis and do it similar to like we do, specifically the Netherlands, where there are rates of 48%, 21% venous thrombosis in COVID patients, higher in ICU patients than non-ICU patients. In July, the first low incidence paper came out from May et al. Comparing ICU and non-ICU patients in Hubei, which is near Wuhan, and then presented at the ISTH meeting in July. And this is the sort of the end of the good data, systematic studies of centers in the U.S. Showing 4.8% in ICU patients and 6.3% in ICU and non-ICU patients. So you can see this huge reported number at the beginning with low cohort sizes, and then when you get up to larger cohort sizes, the numbers come down. They're not zero. I'm not trying to say COVID doesn't cause venous thrombosis. I just think the increase in risk over bad viral pneumonias that we know already is probably 2 or 3-fold, not 10-fold. Next slide, please. So now I'm going to switch to VTE in the hospital. So here's another earlier study, which was one of the first studies to say that non-survivors have high D-dimers and progressively high D-dimers. That's That's in the green, and you can see that the fibrinogen doesn't go down. This is more of a procoagulant phenotype than a consumptive coagulopathy. Next slide, please. This is the latest meta-analysis, if you want to call it that, of VTE incidence in patients hospitalized with COVID-19 infection. And the pooled estimate is at the top, which is not usually what you see. But you can see these, the pooled estimate is 25% from this meta-analysis, but you can see the points are all over the map. The largest reported study had 394 patients, and this was before the Al-Samkari papers were published. Next slide, please. So this is a more recent study. One of the Al-Samkari papers came out in July 2020, 400 patients, one hospital system. They were all given thromboprophylaxis like we would recommend. And they found a rate of VTE in COVID-19 ward patients of 3.5%, in ICU patients 10%, arterial thrombosis patients arterial thrombosis in the ward 1.2%, in the ICU 5.6%. Bleeding was not insignificant, 3.1% in ward patients and 7.6% in ICU patients. I think this is probably more accurate with reality. Next slide, please. Another more recent study, and this one got a lot of headlines. It was a single hospital system in the US, 4,400 patients about. A third received no thromboprophylaxis, 45% received thromboprophylaxis, 20% got therapeutic anticoagulation, not because of a diagnosis of clotting, but because there was a worry. 2% of these patients had major bleeding. They did not report DVT or PE. There were 26 autopsies. 42% of the patients at autopsy had venous thromboembolism, mostly pulmonary embolisms. And the headline that came out in this, and I remember this is where thrombosis and COVID really hit the headlines, with my mom asking me, isn't that what you do, clotting? Anticoagulation, any, reduced the rate of intubation and death. Death by, and the first number is in the ward patients and the second number is in the ICU patients. So it's the first study that sort of gave us a clue that anticoagulation might be helpful. Next slide, please. Here's another bit of information about that. So 3,200 or so ICU patients in a number of centers in the US. Again, a cohort, 1.7% were diagnosed within 48 hours of ICU admission with VTE. Another 6.3% developed VTE in the ICU. There was a 2.8% rate of major bleeding, and 11.8% of the patients were given therapeutic anticoagulation in the ICU without a confirmed diagnosis. And then this trial did a fancy sort of guesstimate of the effect of anticoagulation by randomizing the patients between therapeutic anticoagulation and not therapeutic anticoagulation. And they concluded that therapeutic anticoagulation did not affect mortality. Next slide, please. So there have been a lot of guidance documents based on this limited evidence. So the Anticoagulation Forum said that many patients with COVID are increased risk of VTE. They recommend pharmacological prophylaxis for COVID-19 when patients are hospitalized. They recommend that dosing of the thromboprophylaxis be evidence-based whenever possible. And they have a statement about escalated doses can be used for critically ill patients. That's not better delineated in the paper. They recommend a full 3-month course of therapeutic anticoagulation for patients with COVID who are presumed to have a hospital-associated VTE event, as you would for anyone else with a hospital-acquired VTE event. And there's some caution about APTT if you're going to give intravenous heparin to monitor heparin levels because of some effects of COVID on some of the APTT assays in patients with COVID-19 disease. Next slide. This is the recommendation from the ISTH-DIC subcommittee. It's not that different. So they say patients should get prophylactic dose heparin or low liquid heparin. If they have a worsening clinical situation or suspicion of pulmonary thrombosis, they should be imaged. If there's if they have a clot, you treat them. If you don't have a clot, you can give them prophylaxis, and some of the experts recommended higher doses of prophylaxis. They also tackled if there's a high suspicion of pulmonary thrombi, but you can't image the patient because they're getting, because they have COVID-19 and it's hard to get them to the scanner, or they're too sick to be in the scanner, then you can consider therapeutic anticoagulation. Next slide, please. So the ACC and ISTH together put out statements about not using elevated D dimers as a diagnosis of acute venous thrombosis. They say elevated D dimers are common in COVID-19 and do not warrant routine investigations for acute VTE in the absence of clinical manifestations or other supporting investigations. And if definitive imaging for pulmonary embolism cannot be performed because of isolation, instability, propositioning, clinical suspicion, like disproportionate hypoxemia, unexplained RV dysfunction, traditional VTE risk factors, you can use a bedside echo, get ultrasounds of the legs, or point of care ultrasound. None of these are proven. These are all guidances by experts. Next slide, please. Alan Tran will be introduced by Dr. Bell.
Thank you. I forgot to unmute my screen. Our next speaker is Dr. Alan Tran. Alan is an assistant professor in the Division of General Internal Medicine at Dalhousie University, where he is director of the General Internal Medicine Residency Program. His clinical work focuses on thrombosis medicine, but also has a keen interest in point-of-care ultrasound and medical education. On that perspective, I'd be interested if you have been using point-of-care ultrasound in ICU patients who can't be moved with this. So with that, direct from Halifax, I turn it over to you, Alan.
Thanks for that introduction. Just go to the next slide. So as Dr. Gross had just reviewed, there are quite high rates of VTE in the inpatient setting for those with COVID. And we also know that in the medical inpatient population, over half of the patients who experience a hospital-acquired VTE develop this after discharge. And thus, with these higher rates of VTE in patients admitted with COVID, are these particular patients out of the woods by the time they get discharged from hospital from a VTE standpoint. So as a way of background, this is a summary of 4 trials assessing post-discharge VTE prophylaxis in medical patients as opposed to surgical patients. And in these studies, the patients generally either received 1 to 2 weeks of enoxaparin or the intervention drug at prophylactic doses for 30 days beginning during the hospitalization. So in the EXPLAIN trial on the left, the intervention was enoxaparin. With ADOPT, it was apixaban. With Magellan, it was rivaroxaban. And with APEX, it was betrixaban, another 10A inhibitor. And so all these patients were generally felt to be at higher risk of VTE based on other risk factors. And the most common diagnosis actually in these studies for their hospitalization was a respiratory infection. So among these studies, apixaban was the only one to not find a significant reduction in VTE with extended thromboprophylaxis. And all of them had higher rates of major bleeding with the intervention, except for betrixaban. They all did seem to have higher rates of clinically relevant non-major bleeding, though, which was generally around 1 to 4%. So it's important to note that these rates of VTE that are in these graphs include asymptomatic VTE, and that the benefits were largely driven by asymptomatic VTE as well. That was found at routine ultrasound in follow-up in their protocols. There's another study that looked at rivaroxaban as well called the Mariner study, where heart failure was the most common diagnosis, which did not routinely look for asymptomatic VTE. And this study did find reduced rates of symptomatic VTE without an increased risk of major bleeding. The EXPLAIN trial with enoxaparin and the APEX trial with betrixaban also did find reductions in symptomatic VTE, though these were very small benefits, which was kind of around 0.5% in terms of an absolute risk reduction. So overall, I think this gives us a background that there probably is a small benefit in terms of reducing symptomatic VTE in the setting of medical patients, given extended post-discharge thromboprophylaxis at the likely expense of more bleeding, at least clinically relevant non-major bleeding. Go to the next slide. And so the guidelines from the ISTH and CHEST earlier in the year were agreed on the point of inpatient VTE prophylaxis for all patients admitted with COVID in terms of post-discharge prophylaxis. They really suggested that this should be risk-based, so have a stronger consideration of using this in someone who has a low bleeding risk and a higher VTE risk. And based on some modeling, they felt that there probably would be a net benefit if someone did have a low bleeding risk and their VTE risk was around 2% or higher at 42 days post-discharge. Go to the next slide. So then what are the post-discharge VTE rates in patients who have COVID? So this was a retrospective study based on a continuous QI program assessing hospital-acquired VTE in London. There are almost 3,000 patients admitted with COVID, and they had data on about 1,900 discharges. They all received inpatient VTE prophylaxis, and those who were in the ICU did receive intermediate dose thromboprophylaxis while they're in the ICU. And none of these patients were given post-discharge prophylaxis, but they were all followed for 90 days. Next, please. So overall, they found that there are 84 total episodes of hospital-associated or VTE, and 9 of these occurred post-discharge, so giving a rate of around 5 per 1,000 discharges. And this occurred at a median of around 8 days, but did occur as late as 33 days in the study. They looked at a comparator cohort from 2019 of patients who developed a hospital-acquired VTE and found that that rate was around 3 per 1,000 discharges. And when they analyzed this, the odds ratio was not significant. The next point, yeah. So the odds ratio was not significant in terms of patients who were admitted for COVID compared to the standard medical inpatients who were discharged for post-discharge VTE. Go to the next slide. And so there's another cohort available. This was an abstract form only so far that was presented at the ISTH Congress. And they analyzed 102 patients who were admitted with COVID. And they did, as you can see there, about a quarter of them were in the ICU. They're in hospital for around 10 days, and they had quite high D-dimers on discharge. They followed them up at 6 weeks, and they all had ultrasounds done, as well as a repeat D-dimer. If a patient's D-dimer at 6 weeks was still more than 2,000, or they spent some time in the intensive care unit, they routinely investigated for PE. And of these patients, only about 8% of them received extended VTE prophylaxis. Fortunately, none of them had any major bleeding or clinically relevant non-major bleeding. And of this whole cohort, there's only one VTE found, which was an asymptomatic DVT, and there was no evidence of symptomatic VTE. Next slide. So I think what this tells us is that the post-discharge VTE rates appear low and not necessarily higher in the COVID population, and that pharmacologic VTE prophylaxis post-discharge probably is not needed in most. Of course, patient education and clinical vigilance on the signs and symptoms of DVT and PE and when to present back to hospital should be done in all of these patients. And I think the data available doesn't provide us much granularity in terms of if there's a particularly high sub-risk subgroup for VTE that's specific to the COVID population. There have been some risk assessment models done beforehand, such as one is the IMPROVE score, that these could potentially be used. However, remember that the benefit in terms of symptomatic VTE reduction is quite small, and that these risk scores don't necessarily have any data regarding clinical impact of using it. Next slide. So switching gears a little bit, what about the data in patients who've never been admitted to hospital but are found to have COVID? Well, this is even less overall. So in terms of outpatients, I could find this one prospective study from Germany. They looked at all comers to the emergency department who either had suspected or proven COVID. Only 9 of them were not hospitalized, and none of those patients had VTE at 90 days. Or sorry, at 30 days, I mean. And then an interesting population would be those who end up having a hospital in the nursing home. So in Halifax, we had a large outbreak in one of our nursing homes. And for containment and to reduce exposures, they actually moved many hospital workers to the nursing home itself. So we have no data on these patients, but I think it'd be reasonable to consider VTE prophylaxis in these patients if they would have met criteria for admission otherwise. For the next slide. And then what about if you need to treat someone for VTE who has COVID-19 but does not require hospitalization? So really in terms of efficacy, any anticoagulant is probably reasonable in this setting. The usual caveats of if you're using a DOAC, have some caution in those who are at high risk for unpredictable drug levels. This website here does provide a good drug-drug interaction checker for the investigational drugs for COVID-19 in case any of your patients are enrolled in clinical trials. And then as has been alluded to, if warfarin is the only option for this patient, then it's important to remember the context in terms of the accessibility to lab work for INR checks. Next slide. So overall, the rates of VTE in outpatients with COVID-19 or those who've recovered from it are low overall, and that most patients who are not in the hospital probably don't need pharmacologic VTE prophylaxis, whether they've been discharged from hospital or if they were never hospitalized. And the next slide. And finally, we wanted to summarize some of the ongoing trials. So back when we made this presentation, I found around 34 studies related to thrombosis and COVID-19 on clinical trials. So I tried to categorize them. So there's some observational studies looking at the incidence of acute VTE, as well as the incidence of delayed VTE after COVID. Pregnant patients are often forgotten in many of these studies. So there's an observational study looking at that. Go to the next slide. In terms of anticoagulant dose, this is also being looked at. And sorry, I forgot to mention the numbers beside each category or the number of trials actually looking at this question. So there are some studies looking at weight-adjusted versus fixed prophylactic dosing, intermediate versus standard dose, therapeutic versus prophylactic dose, and I highlighted some of the trials involving Canadian sites, as well as therapeutic versus intermediate dose. Next slide. There are studies looking at anticoagulant selection, so whether low molecular weight heparin versus unfractionated, inhaled unfractionated heparin, and rivaroxaban. Studies of children, again, often forgotten, and VTE prophylaxis in outpatients, so ones who've never been hospitalized but are given an anticoagulant once they're diagnosed with COVID. Next slide. And then looking at adjunctive treatments such as antiplatelets, steroid statins, or TPA in those who have ARDS. So these should be completed within the next 3 to 6 months, and hopefully it'll make decision-making clearer overall.
Thank you very much, Alan. Our next presentation, I think, will be very interesting to particularly my primary care colleagues, but again, all healthcare professionals managing your thrombosis patient virtually in the COVID era, a hematologist perspective. This will be given by Dr. Sudeep Shivakumar. Sudeep is an associate professor in the Department of Medicine, also at Dalhousie University, and a clinical hematologist at the Nova Scotia Health Authority in Halifax. He is director of thrombosis and anticoagulation and the division head of hematology at Dalhousie University. In addition to his hematology training, he has a master's of public health from the Harvard School of Public Health. He is a member of the executive committee of Thrombosis Canada and a platform co-chair at CanVector. Sudeep, the floor is yours.
Thank you, Alan, for the introduction, and thank you, everyone, for attending. So we're shifting gears a little bit and talking about patients who may or are already on anticoagulation and how we manage them during this difficult time. And there are some unique challenges and considerations. We really want to make sure that our patients who are on anticoagulants are not adding to the burden or overwhelming the healthcare system. But at the same time, we really want to make sure that our patients on anticoagulation are getting the best care possible, and we are doing everything we can to make sure they're being safe, being kept safe in this time where we're monitoring and visits are potentially dangerous. So we really have to have a paradigm shift and change the way we deliver anticoagulation therapy by optimizing local solutions while protecting our resources. Next slide. So I'm going to talk about three areas, all brief, but the first will be managing the diagnosis of DVT and PE virtually. The second will be managing patients on anticoagulation virtually. And finally, I will end by talking a bit about perioperative management of anticoagulation and how we can do this with less in-person visits. Next slide. So just as everybody knows, the diagnosis of DVT and PE is a complex one. It's one of the few diseases where we have clinical prediction rules and blood tests and false positives, making it a very difficult disease to diagnose and a scary one to miss. Typically, patients present to their family physician or emergency department with symptoms that may seem like a DVT or PE: chest pain, shortness of breath, leg swelling, leg pain. Pre-test probability rules such as the Wells criteria is used to determine the need for other tests such as blood work, including a D-dimer or imaging. And while we're waiting for the confirmatory test, we shoot first and ask questions later. We give the patient a dose of anticoagulant as long as the bleeding risk is not high, such as a dose of low molecular heparin or a direct oral anticoagulant. And then finally, we use imaging to confirm the presence of a DVT or PE or to rule it out. Now, all of these steps require multiple interactions with the healthcare system. And in the COVID era, we really want to see if there are some of these interactions can be virtual. And, I put some points on this slide, and of course, none of these are perfect, but we can try and switch a lot of our management to virtual care. For example, virtual assessments can be used to determine the pretest probability by telehealth or by Zoom or a similar platform. The caveat here is that a physical exam is not going to be the same. It's not going to be as good an assessment tool as it would be in real life, and that is part of the Wells criteria. But we can work around that to get a good idea of the pretest probability. If the pretest probability dictates that a D-dimer would be helpful, such as if a pretest probability is low and a D-dimer that's negative would rule it out, that can be ordered only if needed, and it can be booked as an outpatient. Imaging can also be ordered only if needed and can be avoided if the pretest probability rule plus or minus the D-dimer declares that it's needed or not. And anticoagulation can be started virtually as soon as the diagnosis is suspected, which has become something that is more feasible with the advent of the direct oral anticoagulants. And of course, once the diagnosis is confirmed, anticoagulation can be continued and monitored virtually, which we'll talk about in the next few slides. So just talking about the patient who does require initiation of oral anticoagulation, such as when DVT or PE is diagnosed. Ideally, this is initiated by clinicians in primary care or the emergency department when the diagnosis is suspected or confirmed. When possible, if this is done in person, then this would be an ideal time to move to remote consultations to start the blood thinner or the anticoagulant and to arrange follow-up by phone or telehealth. It should strongly be recommended to use direct oral anticoagulants instead of warfarin unless there is a good reason not to minimize monitoring and blood tests that may lead to more interactions with healthcare professionals and more exposures. And for patients who are not candidates for a direct oral anticoagulant, consider low molecular heparin monotherapy in the appropriate situation. Patients may need to be educated regarding self-injections, but this usually is something that is quite easily taught and learned. Next slide. If low molecular heparin overlapped with warfarin is the only choice and INR monitoring is not possible, again, consider just sticking with low molecular heparin alone until monitoring is possible. For warfarin or direct oral anticoagulants or low molecular heparin, consider extending prescriptions for 90 days as opposed to 30 days with electronic prescriptions, or provide the prescriptions directly to community pharmacies to again avoid interactions with or exposures to the healthcare system. And of course, our local pharmacies need to be aware of the increased usage of DOACs that's going to be expected during this time, and I think they have seen that. And the provincial pharmacare programs really have to be we have to continue to advocate for our patients that coverage of DOACs should be something that we offer to patients during this exceptional healthcare crisis. And I just bring this up because many of the provinces have approved direct oral anticoagulants in terms of funding during this time, but with stop dates and frequent reassessment of that rule. So just to keep the pressure on, I think is a good thing. Next slide. So specifically warfarin or vitamin K antagonists, there's unique difficulties with this because warfarin management requires frequent blood work for INR monitoring. And many patients are worried, very reasonably so, about the risk of getting blood work. It requires a trip outside the house when we are telling people to stay inside and to avoid crowds. There are concerns about waiting for tests in areas with large amounts of people. Of course, the need for INR monitoring has to be balanced against the risk of being on a drug such as warfarin with a narrow therapeutic range without any monitoring. There's risks of bleeding if the INR is too high and risks of thrombosis if it's not. The one thing just to come back to though is just to go back to some of the perioperative studies that are reassuring when they look at the risk of thrombosis when off anticoagulation for a period of days in patients with atrial fibrillation. It is a low risk, so we do need to monitor these people, but it is a low day-to-day risk, just to keep that in mind. Next slide. So there are ways we can mitigate frequent blood work. One is to consider less frequent INR draws. For patients that are on stable doses of warfarin with a therapeutic INR, it is reasonable to extend the INR frequency to every 8 to 12 weeks, as opposed to more frequent than that or monthly. So it's just something to consider in the stable patient. This may be more appropriate for patients who have a lower thrombotic or bleeding risk, and that may be somebody without a fresh clot, or DVT or PE that's over 1 to 3 months old, atrial fibrillation with a low CHAD score, or a low-risk mechanical aortic valve. There are other ways to mitigate the risk of exposures to healthcare professionals and patients with getting frequent blood work. Some labs are using time tickets to minimize patient exposures. Patients wait in their car until the time for their test. Quebec has community health centers that expedite the process of getting blood work. And having booked appointments for blood work is there to reduce the exposure of patients to other people. But of course, there are difficulties with this in terms of wait times to really get through on the phone. So we still have some work to do. As well, there are alternate ways of monitoring the INR in the warfarin patient. Some pharmacies have point-of-care machines, and some provinces have programs where pharmacists can check the INR and adjust the dose. Point-of-care machines can be purchased by patients. The machines do vary in price, but are a one-time cost. But the test strips are an ongoing cost and can be quite expensive. These are not typically covered, so it is really only appropriate for select patients, unfortunately. Next slide. And then finally, to consider switching to a direct oral anticoagulant. Direct oral anticoagulants are approved for the management of DVT and PE, as well as stroke prevention and atrial fibrillation. There is no routine lab monitoring needed, and rivaroxaban and apixaban specifically do not require low molecular heparin run-in or overlap for the acute venous thromboembolic event. As I mentioned, some provincial pharmacare programs are making exception for coverage during this time. I know Nova Scotia is. It had been set to expire sometime this summer, and they did extend it, but again, there's not much clarity about how long they will extend it, so stay tuned on that. And I will say that this is the approach that is recommended by the Canadian Cardiovascular Society to prefer a direct oral anticoagulant. So in terms of the patients who are already on anticoagulants and how we can safely provide follow-up, well, one thing to always consider is anticoagulation still required. It may well be, but it is always good to reassess the risks of thrombosis and bleeding in any patient to ensure that staying on an anticoagulant is the right move for them. As well, we talked about remote monitoring with telehealth visits, video or telephone visits, and this can definitely be done for the patient on anticoagulation. it's important to make sure we're asking patients about any bleeding symptoms, checking adherence, and any new medications, as there may be potential drug-to-drug interactions. But these are things that can be done virtually. And to avoid repeat labs if patients are previously stable and if it's unlikely to have significant clinical impact. So coagulation tests in the patient on the direct oral anticoagulant is not likely to help in any way. So it would not be a routine test we would recommend getting. As well, if a patient is on anticoagulation, it is good to just do our usual education about what to watch for, as bleeding is the side effect that we are most concerned about. Bleeding is a broad heterogeneous category, so it is important to point out, bleeding that is serious, life-threatening, that requires in-person immediate intervention versus bleeding that is a minor issue that could be addressed at home or with phone support, such as a minor cut or bruise or a nosebleed that stops on its own within a few minutes. There is a website there that has some resources for patients, just as a resource for you. And it is important, of course, that all patients are, everyone is aware that specialist support should be looked at for any significant concern of bleeding, of course. Next slide. So just a bit more about managing these patients on all anticoagulants virtually. The risk of bleeding is less than 2% per year, and of course, some populations are more at risk of bleeding than others. And I did talk about checking in on patients by phone or virtually. The only other point I'd make about this is that one of the most common calls we get are for patients on warfarin with a high INR. And the CHEST guidelines, the ACCB guidelines can be used, and it is often the case that an intervention is not necessary other than holding warfarin alone if the INR is less than 10 and there is no bleeding. So these guidelines may help avoid interactions with the healthcare system. Next slide. So finally, I'm going to be talking about the perioperative management of anticoagulation. And of course, this is an issue because for any invasive surgery, we always want to discontinue or hold the anticoagulant to prevent a bleeding complication, but we are concerned about a preventable thromboembolic event if the anticoagulation is stopped too early or for too long a period of time. So it's that delicate balance. I think the first step in a patient who requires perioperative management of anticoagulation, and this can be done virtually, is what is the bleeding risk of a procedure? And there are the procedures that are a very low bleeding risk, and then there is everything else. And I think this is the big distinction that needs to be made first as a first step. The very low risk bleeding procedures, such as dental procedures, local skin biopsies, cataract surgeries, and diagnostic scopes, do not necessarily need their anticoagulation stopped. And that takes out a whole range of problems in terms of logistics of stopping the anticoagulant. Basically, everything else, you have to consider stopping the anticoagulant. Next slide. The problem, of course, is that warfarin has a very long half-life. And given this long half-life, it has to be stopped 5 days before surgery to reduce the risk of bleeding. Next slide. In the past, we used to bridge the vast majority of atrial fibrillation patients with low molecular heparin. We'd put them on a drug with a shorter half-life to cover or bridge them while they were off the warfarin to reduce the risk of stroke in atrial fibrillation patients. We are lucky to have Dr. Duquetis as one of our panel and also the lead author of the bridge study published several years ago, which really answered this question in a randomized controlled trial. Basically, patients who required interruption of warfarin for atrial fibrillation for a surgery or a procedure were included in the study, and they're randomized to bridging with heparin or low molecular heparin versus no bridging. And the only things I'm going to point out on this slide is really the outcomes. And you can see the table has the no bridging arm, which had about 900 patients, and the bridged arm, which had 900 patients just under that. And if you look at the difference in stroke, there is no significant difference between those two groups. If you look at the difference in bleeding, there is an increased risk of bleeding in the bridging arm, and that is significant. And there's no mortality difference. So really, bridging with low molecular heparin in atrial fibrillation patients does not reduce the risk of stroke and increases the risk of bleeding. Next slide. So we can simplify our perioperative management of warfarin algorithm, and this is very easy to do virtually. For atrial fibrillation patients, before the surgery, stop the warfarin 5 days before. Consideration can be given to repeating the INR the day before the surgery. Post-op, restart the warfarin. There are special populations which would you may consider conferring with a thrombosis consultant, antiphospholipid antibody syndrome, mechanical valves, somebody with a recent DVT or PE or a recent stroke. They do not fit into the bridge study inclusion criteria, so very reasonable to seek consultation, but otherwise a simplified algorithm is very reasonable and appropriate. Next slide. In terms of the direct oral anticoagulants, stopping these drugs 48 hours before major surgery seems reasonable. This is a simplification, but it's based on the half-lives of these drugs, and as long as the creatinine clearance is adequate. We do have a study that used a pre-specified algorithm for stopping these direct oral anticoagulants called the PAUSE study, where drugs were anticoagulants were stopped a pre-specified amount of time before the surgery, and this was a safe practice. I believe the next slide. This has been incorporated into the perioperative anticoagulant management algorithm tool on the Thrombosis Canada page. So the Thrombosis Canada website will guide you to this, and really you just click through the type of surgery, the anticoagulant they're on, their creatinine clearance, and it will tell you an evidence-based approach to when you should stop the direct oral anticoagulant. Next slide. And finally, post-op, it is important to just have some thought about when to restart the blood thinner. And this is because the direct oral anticoagulants have a very quick onset. So starting it right after surgery, like we would with warfarin, which takes a few days to get to a therapeutic level, may increase the risk of bleeding. And again, this is also on the Thrombosis Canada website, but if there is any concern about high risk of bleeding after a surgery, instead of starting it, a day after the surgery, consider holding it for 2 to 3 days until hemostasis has been achieved and the bleeding risk is lower. So next slide. So in summary, in the COVID era, I think remote management of thrombosis and anticoagulation can be done. Utilizing pretest probability models and D-dimer testing can help reduce exposure in the emergency department. Remote management of anticoagulation is made much easier with the direct oral anticoagulants. And recent evidence in perioperative management of anticoagulation really has made in-person visits less necessary. Warfarin patients, specifically atrial fibrillation warfarin patients, do not usually require bridging. And a direct oral anticoagulant patient can be managed with a pre-specified algorithm. I think that's my last slide, so thank you.
Thank you very much, Sudeep. A very practical approach to managing anticoagulation in the COVID era. Thanks again, that was awesome. Continuing on the theme of practical approaches, we're going to go through some case studies, which I think are very typical for primary care physicians, but again, also for any other healthcare professional managing these patients. Just before we start, I would like to remind all the participants that where there is a Q&A function available at the bottom of your screen. If you just hover over the bottom, you'll see a Q&A symbol, and please don't hesitate to type in any questions that you may have. I'll also remind you that there will be a poll at the end to assess your response to this program, and that is available by going to pollev.com on your computer or texting thrombosis to 37607 on your phone. Texting thrombosis 37607 on your phone. So let's start with our first case. A 55-year-old female patient calls about a 3-day history of progressive left leg pain. She describes unilateral left lower leg pain with redness and swelling from the knee to the foot. And when you ask her, she will tell you that it pits with local pressure. She has no systemic symptoms, chest pain, or shortness of breath. There are no clear provoking factors, but she tells you that she's been lying in bed a lot during COVID. There's no specific history of trauma. Past medical history reveals obesity, type 2 diabetes, mild hypertension, but no previous thrombotic or VTE events. Her last blood work was done about 9 months ago and was all within normal limits, and it included her CBC and her creatinine. She is assessed by you on a telephone consultation, and we ask, is it safe to initiate empiric anticoagulation therapy by telehealth? And I think that Sudeep covered it very nicely. Even though we don't see this patient, it is still very possible to invoke the Wells criteria for DVT. She has calf swelling, greater on one leg, clearly. She has pitting edema in a symptomatic leg, giving her a Wells score of at least 2, just based on what we can gather from her history. So she is indeed at high risk. And this is a drum that I have been pounding very loudly for several years now to my primary care colleagues, that in cases like this, as Sudeep so very nicely put it, the approach is to shoot first and ask questions later. And indeed, empiric anticoagulation can and should be initiated by telehealth. The ACCP recommends that in cases of high risk, such as this, that unless we can get an ultrasound within a few hours of this patient presentation, that we should not delay anticoagulation. The risk of delay or far exceed the risk of the anticoagulation itself. Next slide, please. So the actions that are taken in this patient, including faxing a prescription, in my mind, for a DOAC to a local pharmacy. DOACs have certainly improved our ability to manage such patients remotely and quickly. You may, in fact, wish to speak directly to the pharmacist to discuss the importance of initiating therapy in this patient and perhaps delivering the drug to the patient. The recommended drugs and dosages for acute DVT management are specified there. Both apixaban and rivaroxaban do not require low molecular weight run-ins, as was mentioned by Dr. Shivakumar. At the same time, this patient is going to require confirmation of her disease, and it would be recommended to send a requisition for a venous duplex compression ultrasound. Also, I think you should provide that patient with a lab requisition to assess the baseline hemoglobin level, any other abnormalities that you may be searching for in the biochemistry, and certainly renal function to ensure that you are correctly dosing the NOAC. I'll also put in a plug for the patient management section of the Thrombosis Canada website, where you will find the form on the right side, which can also be emailed or mailed or sent somehow to your patient, which explains to them the disease that they have, the possible complications, and the importance of proper management. So if we move forward with this patient is indeed sent to a local vascular laboratory from the requisition that you have faxed in remotely, and it confirms the presence of a DVT in the popliteal vein. You can see the image on the right showing the popliteal vein does not compress adequately, confirming the diagnosis, and a second telehealth visit is arranged with the patient. Now, the questions that are going to come up now are, what do you recommend for treatment and follow-up? Well, you know, just like in the era, the non-COVID era, the good old days, shall we say, this patient is going to require the same form of treatment for their DVT. This is an unprovoked DVT, certainly a minimum of 3 to 6 months of anticoagulation, and then a consideration beyond that, whether or not this patient is going to require extended care. And that can be done through a timely referral to your local thrombosis specialist. And the next question is, when should this patient be seen in person? You know, and I think that would be an assessment that is going to be made between you and the patient. One would have to assess the risk and benefit of potentially exposing this patient to the office environment where COVID could be an issue. this patient can probably be managed without an in-person visit. However, if there is a suggestion of complications, if you wish to spend more time with the patient, perhaps provide the reassurance that we spend so much time doing in primary care, an in-person visit may well be appropriate. But personally, I feel that this is going to be a decision that is going to be shared on the phone between you and your patient, and both of your tolerances for in-person visits during this time. So we also put up another potential complication or potential difference, in this case. What if the patient doesn't have a DVT confirmed on ultrasound, but instead shows a superficial vein thrombosis? And I'm not going to go into any detail on this, except once again to refer you to the Thrombosis Canada clinical guides, which provides an algorithm for the management of suspected and confirmed superficial vein thrombosis, as well as the recommended treatments for this condition based on the severity of the disease. And you can see them all on the right side of your screen, all of which are completely available on the Thrombosis Canada website. Just before I move on to the next case, I'll put it forward to our panel. Peter, Jim, Alan, Sudeep, any comments on this suggested management?
No comments for me.
We never used to see patients with the superficial thrombophlebitis, but then we ran a little study with one of the DOACs, and we kind of asked for these patients, and so we now we see them quite frequently. Yeah, I mean, it's a common, very, very common scenario. Superficial thrombophlebitis is 10 times more common than DVT.
And I just want to add, sorry if I cut you off there, Peter. I just want to add that the superficial femoral vein is a deep vein, so it's just a poorly named vein, so that can sometimes throw people off, and you wouldn't use this algorithm for that.
Correct.
I also would like to point out that many of my colleagues are reluctant to start anticoagulation until a DVT has been confirmed. Jim, would you like to, can I get you to comment on that?
Certainly, I think there's ample evidence showing that it is very safe to initiate anticoagulant therapy on the premise that the patient may have a DVT and not wait for ultrasound confirmation. That's been proven in multiple studies, and I think should be the standard of care.
And early treatment prevents post-thrombotic syndrome also, so the quicker you treat, the better.
Thank you. Next slide, please. Our second case is switching from warfarin to a DOAC. So this is a 79-year-old patient who's been receiving long-term treatment with warfarin for atrial fibrillation, and you wish to eliminate her need for INR testing during the COVID era. And a reasonable strategy for that would be to switch her to a DOAC. And how can you do this with minimal laboratory involvement? Can I have the next slide, please? So these are the recommended INR levels when apixaban, rivaroxaban, dabigatran, and edoxaban can be initiated in patients who are receiving warfarin. However, this would involve your patient having repeated visits to come to these levels. Can I have the next slide, please? But a sensible, practical approach that has been suggested by Thrombosis Canada during this time would be much simplified from that, and it would involve really only obtaining a baseline INR. At that time, you may wish to check the patient's hemoglobin level and creatinine in order to ensure proper dosing, but you would advise the patient to stop the warfarin after that day's dose and to initiate the DOAC according to the baseline INR, a very practical approach. Patients who are between 2.1 and 3.5, a 4-day waiting period is recommended. So if their last dose was Monday, you start them their DOAC on Friday. If their INR is less than 2.0, then all of the DOACs are fine to start immediately at that point, and you can have a 1-day switchover, 1 day warfarin, the next day DOAC. Patients whose INR is elevated up to 4.5, might want to give them an extra day to bring their INR down to safe levels as recommended in the product monograph, so perhaps a 5-day wait for those patients. And for those patients who are out there with an INR above 4.5, you may wish to recheck their INR on day 5, and that would require an additional laboratory visit and start if the DOAC is less than 2, otherwise following the recommendations that are shown above there. Next slide, please. And here are your DOAC options, either a twice daily option with apixaban or dabigatran, or once daily options with edoxaban or rivaroxaban with the appropriate dosage changes. Now, in order to ensure that the correct dose is being used, I would urge you to consider the anticoagulant dosing tool that is available on the Thrombosis Canada website, which asks you only the patient's age, weight, and most current serum creatinine, as well as ensuring that they are indeed indicated for oral anticoagulation with their CHADS risk factors. And the recommendation for the dosing is provided below. And you can see in this particular case, 79-year-old weighing 66 kilograms with a serum creatinine of 122 would require the doses that you see in the bottom of your screen for the various drugs that are available, as well as other treatment recommendation. Our third case is anticoagulant-related bleeding. This was nicely touched on by Sudeep. So we've got a 60-year-old male on long-term warfarin for a mechanical aortic valve. He calls your office because of nosebleeds that have been going on for the last 3 weeks. He doesn't want to go to the emergency room. He's not taking aspirin. He's not taking NSAIDs. He describes the bleeding as intermittent from either side of his nose, lasting up to 60 minutes. He has no other visible bleeding or bruising. He indeed has lab tests done which show a mild hypochromic microcytic anemia and an elevated INR at 3.7. So what do you recommend for warfarin dosing and INR monitoring, and when and how would you give vitamin K? The answers to these questions are readily available on the Thrombosis Canada clinical guides under warfarin management of out-of-range INRs. Next slide, please. So the things that I think you're going to initially ask is this patient on aspirin or NSAIDs? And we've established in our case it's not. Is a switch to DOAC a possibility for this patient? And in our case, this patient, that is not a possibility, considering the mechanical aortic valve. And, you know, should you consider low-dose DOAC in these patients? And if we had a little bit more time, I would put it out to our. You know what? I'm gonna put somebody on the spot. Alan, can I put you on the spot on this one? Would you consider a reduced dose? Let's forget about the mechanical valve for a moment. Let's assume this patient is just on a DOAC. Would you consider a reduced dose for this patient?
Sorry, on a DOAC for AFib though, or
yeah.
for?
Yeah.
Yeah, and the creatinine clearance was looking, just to confirm I have all there.
Yeah, let's say he is indicated for full dose DOAC, but he's bleeding and having these difficult nosebleeds.
Yeah, that's a great question. So it's you know, I guess it wouldn't necessarily fit in terms of what's been studied, and the worry would more so be, are you providing an effective anticoagulant for this patient, or are you just exposing him to a slightly higher risk of major bleeding without much of a benefit? So if you know, first of all, is always trying to source control, right? If we can fix the sources of bleeding, whether with, you know, cauterization or whatever we need to do to fix those nosebleeds, then that would be the preferred management from me, while keeping them on the full dose DOAC if they haven't had significant changes in terms of their hemoglobin.
Okay, thank you. Next slide, please. So, you know, I think one thing that I want to remind all participants on the web is discontinuation of anticoagulation in patients who are clearly indicated for it for relatively minor bleeding episodes like epistaxis, bruising, hemorrhoidal bleeding, or subconjunctival hemorrhage should not be considered. Some forms of minor bleeding have to be tolerated by patients on anticoagulation. Perhaps a reduced dose, perhaps switching to a different NOAC may be helpful for these patients. Next slide, please. The last case is about perioperative management, but sadly we've only got 5 minutes left, so I'm going to skip forward and we'll skip this. I thought this was beautifully covered by Sudeep. I will remind all of you that there is a an algorithm on the Thrombosis Canada website that is very easy to use and can make you all relative experts in perioperative management of anticoagulation based on the PAUSE study. That's what the tool is based on. I want to take you a moment to remind you to please complete the evaluation for this session. The website is shown for you there. I also want to remind you that a repeat of this session will be available recorded at 7 p.m. this evening. I would also like to remind you that Thrombosis Canada, in order to support this session, has received the support of these sponsors that you see on your screen. It is possible to interact with members of Thrombosis Canada as well as representatives of these companies at our virtual exhibit area, the link to which is available to you on the conference website. Please consider visiting our sponsors who have been very cooperative in allowing us to present this entire program to you. Next slide, please. So with that, I would like to take a moment to thank all of you for attending today. I would like to thank all of our speakers for what would be considered most excellent presentations on their topic. I want to again remind you to complete the evaluation which is necessary for the accreditation process, and that this program is accredited by the College of Family Physicians, the Royal College for Specialists, as well as the College of Pharmacists for our pharmacy colleagues. Please consider visiting the Thrombosis Canada website regularly. This is a moving target, not only thrombosis in general, but very specifically COVID and thrombosis, and we update regularly. So with that, I will wish you all a good afternoon. And again, a thanks to you, our speakers, and our sponsors for allowing this program to move forward. Thank you. Bye-bye.
Great. See you guys.